Hey, what's up, everyone? Welcome back to the Fat Muscle Project podcast. We've got a hell of a show lined up today. I'm John Gorman, one of your hosts. We got Lisa Franz in the house. Lisa, what's going on? How are you?
I am very well excited to speak with you and with our wonderful guest today.
Yeah, so we want to go ahead. Jordan, welcome to the show. This is not the first thing that we've all done together. You've been part of numerous seminars and stuff of that nature, but this is your first time on the podcast. Welcome.
Yes, I'm very excited.
You're at work right now, correct?
I am, yes.
So if you would, I'm going to do a little quick introduction on how we kind of met, but
Sure.
then I want you to really kind of dive deep into what you've done, where you started, and then we're going to have an awesome hormone lab Q and A. So I met Jordan for the first time. We did a Premiere U menopause event on that movie, The M Factor, and I got invited to speak as a guest, and I didn't know anyone there. I was going to talk about supplements for the menopausal female. And that was really fun. And I'm not the menopause expert. Okay. I work with a lot of clients that go through menopause and I'm super familiar with labs and like the basics to look for. So I show up to this panel and there's trainers, there's sexual experts, there's the supplement guy like me, kind of the bro. And then we've got Jordan on the panel. And I quickly thought, okay, she's the nurse practitioner, she's our medical professional. I'm going to see what I don't know. And I quickly learned very fast. There are people in the industry that understand labs and hormones at a certain level, but then there's people that get to that next level. And I learned a lot from you, Jordan. And I thought, okay, this is something we've got something here because now I can learn from her. That was kind of my first introduction, and since then we've started Premier U, the telemed side, and you are seeing literally all my clients, my
Hmm.
family, my son's mom, Leslie. I'm involved there as far as like getting my own health checked and everything there. So you're someone that I trust exclusively. And for our listeners, what I want to do is I'm just painting the picture here. Jordan is the best of the best. And I'm not saying that because we run a business together. I'm saying that because you guys understand I won't say that unless it's true. For her to see my family specifically, that's very, very important to me. So I'm gonna blow you up there so everyone understands just how important you are to us. And then finally, Lisa, you first met Jordan at the Fat Muscle Academy.
Yeah, absolutely. And since then, we were just speaking before I hit record. I have literally before this podcast received an amazing client voice note, and she was like, Lisa, since I started working with Jordan, my life has been flipped upside down. I can't remember the last time when I've had night sweats. I am clearly leaning out again. I am feeling so much more energized. I'm not feeling the pain, the joint pain anymore. And she was just like singing the praises without knowing that I was speaking to you today. So I was like, oh, this is amazing. Very cool.
So Jordan, if you would, now that we've hyped you up, no
I
no
love it.
pressure or anything. I know you do. You don't bat you pressure does not bother you. Let everybody know a little bit more about you, and then if you would, kind of dive into your journey as a nurse, and then your personal transformation is top notch. So go ahead and
Yeah.
take it away.
Yeah, so I started out, I've actually been in the medical field since I was in high school. I actually got my CNA in high school program. So I've been in the medical field since I was 17 years old. I knew I wanted to most likely be in higher level as a provider. At first, I kind of wanted to be a chiropractor, actually. I shadowed several of those and realized very quickly I did not like the insurance game that chiropractors have to play. And back then, there wasn't a lot of cash-based chiropractor. So I'd always kind of lean more towards like holistic root cause medicine. But then when I went and got my nursing degree, I wanted experience. So I decided to take a ER position at a level one trauma center in St. Louis Barnes Hospital. I was an ER nurse for 5 years. I learned a ton since it is that level one trauma, as well as you get to behave more like a provider in that setting because it's all hands on deck kind of thing. So I got my nurse practitioner because I really wanted to make a difference. I was having a lot of patients come into triage, into the emergency room, and I'm thinking, hasn't your primary care doctor talked to you about these things? Like, why are you in the emergency room, right? So there was that huge disconnect between like what is emergent, what could have been preventative. I was also seeing a lot of heart attacks, strokes, things like that too. So I actually dove like head first into hormones. My first NP job was at a men's testosterone clinic. So I helped grow their clinic from one clinic to 4 to 5 throughout the Midwest. And it was great. You know, I learned a ton. I felt like I was actually helping people, but it wasn't challenging enough for me at that point because they were just doing testosterone occasionally, you know, some weight loss, HCG, phentermine, things like that. So I started taking on some high blood pressure patients, some prediabetes patients in that space. But I felt like I had outgrown that. So I decided to take an internal medicine position where I could focus on more metabolic health things. So I did that for a few years. I found that once again, it's a very reactive healthcare system, a very sick care system. I felt like I was a band-aid station for the majority of my patients, and I felt like I wasn't able to make a difference. My personal health was also struggling. So I had had my second daughter. You know, I was 60 pounds overweight, having a lot of hormone related issues. I also was personally dismissed by the current healthcare system. So, over the last 5 years, I have invested in my education. I've personally dealt with my own hormone related issues that were dismissed regarding thyroid, regarding insulin resistance, regarding PCOS, because I didn't fit kind of that classic model of PCOS that I was definitely dismissed for having that. So I personally have lost almost close to 60 pounds on my own journey within the last 3.5 years. Once again, I live and breathe this. This is what I do. And ultimately, patients, I just want to get down to like, okay, what is the root cause issue to why you're having XYZ? So, but that's Premier U, and that's kind of where it was developed.
Yeah, it's so perfect. We all work together so well because everything that you're super interested in, you have a ton of expertise in. That's a lot of our clients, like Lisa's client that she sent to you, right? And like my clients that I send, it's kind of that next level. It's not just TRT and, you know, a little bit of stuff here and there. It's really a deep dive on all that. I do want to sidebar real quick before we get into
Sure.
this Q&A. I know that there's potential nurses out there listening and they're interested to see, okay, I want to see what an NP, a nurse practitioner, knows, but I want people that don't understand nursing to understand the level that NPs are at now. It is so, so crucial. So, through my eyes, the way I see it, is you have docs up here at the top. But I mean, just right there, up there with the doctors this day and age are nurse practitioners. And I think we see less, and you could correct me if I'm wrong, Jordan. I
Mm.
think we're seeing less people become doctors and more people become NPs because you guys are really the ones in the trenches handling a lot of things like this. So to me, I mean, you're just almost pretty much as valuable as a doctor. Is that the way the industry's kind of gone?
Yeah, definitely. And I would say from my years of experience too. So technically in the state of Illinois, I don't have a collaborating physician. I independently practice. So I am not under anyone in the state of Illinois. So, and it's just from the years of practice, continuing education, things like that. So, I'm very highly independent. Yeah.
Yeah, yeah, and that's I wanted people to understand just how high up nurse practitioners are. A lot of
Yeah.
people hear nurse and they don't know what an RN is or an MP, and I get that. So
Mhm.
wanted to paint that picture like we definitely have someone here that can treat you at the highest of levels. So, Lisa, do you have anything that you want to talk about before we get into this Q&A?
No, I'm just really excited to dive into lab work and yeah, this Q and A in particular. So why don't we get started with that in the sense of what's some of the most common lab work that you tend to run with clients, or I guess if we want to tackle it from the other side, what are some of the most common issues that you see people come to you with?
Yeah, so definitely I would say complaint wise, fatigue is really high up there, followed by really brain fog. That's also another one. Maybe cognitively, they're kind of struggling. followed by low libido, low skeletal muscle mass. And I think just being tired overall is one of the most common things patients are seeking me for. Thyroid management, I treat a lot of thyroid patients, so I have quite a reputation in our area for managing thyroid, which is great. So I do treat a lot of those. And I would say that regarding labs that are abnormal, low progesterone for sure, because progesterone starts to slowly decline in our early 30s. And actually, I'm seeing it even earlier. I do a lot of progesterone prescriptions out my door. Cortisol, that too, I think that, and you guys talk a lot about cortisol, but we always worry about too high of cortisol, but a lot of times, sometimes that curve is too flat.
Yeah.
So, which is really detrimental long term. So it's just having that awareness that maybe they have some high cortisol symptoms, but maybe it's actually low cortisol that we're dealing with. And I don't know if you guys can kind of speak to that as well, if you see that a lot.
So it's definitely something on my end where I've seen people so stressed out for so
Mhm.
long that their cortisol was so high. Now it's bottomed out, and we're seeing adrenal insufficiency and adrenal
Right.
fatigue. And a lot of people, I know before I even started understanding labs, I would hear adrenal fatigue and I would think, oh, someone's taking in too much Splenda or something like that, right? I didn't understand what it was. So, highly stressed people over time, especially now that, I'm getting older, I'm seeing it start to flatline, Jordan. And that's
Mhm.
a very hard, long, patient process to fix. Are you seeing more flatlined, lower cortisol, adrenal fatigue people? Or are you seeing more high cortisol?
Well, I mean, it kind of a mixture of both, honestly. So, really low, the curve is inverse, is what I'm seeing a lot of times with my women. It's super flat in the morning because Lisa
Yeah.
can also speak to this. They're not getting AM sunlight, they're not getting that natural circadian, and she's nodding her head, circadian rhythm, all the fun things there. But then it's spiking at night when it should be lower. So, the curve is often inverse for my patients. I prefer saliva cortisol testing. 4 point saliva is gold standard. Unfortunately, is not covered by insurance, but it's only about 99 bucks. It's pretty cheap. Kits mailed to your house. You kind of do it and you send it back in. Sometimes I will do the spot check, AM cortisol. It's not on the serum testing. It's not perfect though. So if you really want to see that curve, I prefer the 4 point saliva.
Yeah, typically my first inclination that something's not right. Of course, there's a bunch of other markers we'll probably talk about later. Like if
Mhm.
reverse T3 is real high, I know they're stressed, right?
Yep.
But if I see on that serum cortisol, their cortisol comes back at like a 4 or a 6 or something, and that tells me, hey, on the blood work, it's low in the morning. We probably need to do a deep dive. That's
Mhm.
where I love the 4 point cortisol.
Yeah. Yeah. And some women, honestly, I'm just doing it out the gate because I already know from my brief 5 minute interaction with him. I had a telemed this morning and I'm like, yeah, we're gonna jump straight to saliva. So you
Yeah.
can just kind of tell because I don't want to add in adaptogens in the wrong place either.
Yes. That's so important, right? Because a lot of people out there, I would say John Gorman 5 years ago, and I've got it right back here behind me. Here, Cordy's, ashwagandha, hammer,
Yep.
hammer, 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 but they're not, their cortisol's low. So like that to me was a mistake that I didn't understand. Yeah.
Yeah.
I would,
So
I'd love to hear,
oh,
sorry to cut you off. I would just love to hear some of your strategies because you mentioned low energy is something very, very common that you see, and I'm sure that resonates with a lot of the listeners as well. So once you detect that, what's often a course of treatment, or is that hard to say?
it's definitely hard to say because there's so many factors that go into that. You know, are they not getting good quality sleep? Which John, you hound your clients on sleep, which I love, but it's like, okay, even if they're getting good hours of sleep, are they getting good quality sleep,
Yes.
right? Are they waking between the hours and 1 and 3? Are they getting up to urinate in the middle of the night? People think that getting up to urinate in the middle of the night is a normal part of aging. It's actually not. It's not a
Yeah.
normal part of aging. So it's typically a cortisol surge problem, sometimes low progesterone, that kind of thing. But um, Yeah, I mean, I would say that's definitely a loaded question. If their testosterone's low, if their progesterone's low, you're going to manage that. Look at their electronics. Are they using their phone? Are they using their tablet before bed? All those kind of basic things that I think often get missed by hormone clinics. Like, oh, these hormones are going to be life changing for you, but they're not talking about the lifestyle. What I like to talk to all my hormone patients, regardless if they're male or female, are like, the hormones are tools in our toolbox, but we have to set yourself up and surround yourself with proper nutrition and other lifestyle modifications.
So if I know we're about our next question's about TRT and part
Mhm.
of this is into that, but let's talk real quick about fatigue and let's talk about brain fog if you don't
Yeah.
mind. A lot of people don't understand it. And I learned a lot really from listening to you and from the M Factor movie. With brain fog, a lot of that time that can be tied to low progesterone and
Yes.
how important that is, low estrogen, which no John Gorman 10 years ago was like, low estrogen, it's great. You can burn fat a lot better. Like I didn't get it.
Uh-huh.
Right? But there are also things like you actually spotted it on my labs, and Brandon, who works with me, our other, he's our PA, Brandon Williams. My cholesterol was very low. My estrogen was on the lower side.
Mhm.
And I was having a lot of brain fog. Can you talk about some of those things that people that you spot that people don't understand that you can help fix?
Yeah, I think definitely thyroid too. I'll just kind of jump that
Yes, yes.
in. The subclinical hypothyroidism, the Hashimoto's that hasn't been diagnosed appropriately, not just looking at TSH, but looking at free T3, free T4, and reverse occasionally there too, making sure that cycle is kind of doing what it needs to do. But I think that and gut health is a totally separate,
Yes.
podcast that we can do, but we have to sometimes start there, kind of clean the gut up a little bit. That way, the hormones and everything I want to give you, that it's in a good space. Gut health is hard, is kind of what I would say. And so sometimes it's hard to start there with certain clients and certain patients, but it's definitely imperative that on your journey, we do kind of get that gut where it needs to be. But even something as simple, John, as not necessarily maybe your clients, but some of the, as you would call, Gen Pop
Yeah.
patients, B12 deficiencies. My
Yeah.
gosh, MTHFR, methylation problems. Sometimes if I just correct their B12, their cognition improves. So, basic things like that, where a lot of the other stuff that you're asking is very individualized when it comes to the patient and what's their perception of brain fog. Is it actual memory issues? What's their definition of brain fog?
I think that's really good
Well,
that you're so detailed, even just in the sense of meeting the client where they're at with their language, how they're expressing themselves and what they're experiencing. And I guess to backpedal just a little bit more, when it comes to tests, you've mentioned several there. You mentioned the
Yeah.
saliva test, you mentioned others. What are some tests that people should run on a regular basis or just in general, what you like to run with your clients?
Yeah, so obviously CBC with differential, because I do look at that differential to kind of see, because sometimes if like mean platelet volume MPV is high, we have some non-specific indicator of inflammation kind of going on there, maybe calcium buildup on the major arteries. So CBC with diff, comprehensive metabolic panel, looks at kidneys, liver, make sure everything's great there. TSH, free T3, free T4, estradiol, progesterone for women, sometimes men too. I have a few men on progesterone actually, which is another separate conversation for a different day. And then sex hormone binding globulin, that's super important to see, is their total testosterone kind of bound up? Is that why their free testosterone is low? So I kind of throw out some other labs there. My men, I'll spot check a PSA just because I have them. And it's like, hey, I don't know the last time or when you're going to see somebody for a prostate exam. So I will still spot check that, even though I know that's very controversial. Vitamin D, vitamin B12, occasionally B6, depending on if they have some neurological stuff going on. I would say that that's basic labs, and then we can kind of add on from there.
Awesome.
yeah.
Great.
DHEA. I forgot about DHEA as well. Obviously, it's talking about adrenal issues. Sometimes that high cortisol can also drive down sodium too. So that's where I look at that.
I know real quick before we jump to the TRT section, this kind of
Yep.
ties into that. So you had mentioned just a lot of fatigue and not feeling good. A lot of the first signs that people that have low testosterone that they have is low energy, low
Yes.
motivation, a lot of fatigue. And Lisa, sorry, I'm jumping in on your question here, but this next one is kind of tied to that. So,
Mhm.
a lot of women are scared of TRT, of testosterone replacement. What are the things that you talk to them to help them understand why it's important? Because
Mhm.
especially like even when you watch the M Factor, they don't really talk about testosterone as much as I feel like they could in the movie. They talked about
Yeah.
progesterone and estrogen, but I think TRT is one of those things, especially in our world, people that are working out. It's highly important. What are some of the things that you help women understand about why it's so important?
Yeah, I mean, I think that there's a lot of fear surrounding all hormones still, honestly, regarding any prescribing of hormones. So when I talk about hormones, I think it's important I say this now. I mean bioidentical hormones, which is like the same chemical structure your body recognizes as its own hormone, not synthetic hormones really there. So kind of keeping that, laying down that foundation. But then also testosterone is a great tool in perimenopause. First hormone I typically introduce is progesterone, sometimes, and then it's usually testosterone because it's going to convert like 0.01% into estrogen. So just enough kind of to help out some of those lower estrogen problems that start to spike and drop in that perimenopause. Um, what would I say is that it's important to know, and this is something I deal with in clients that I see of your guys's, is they talk about weight gain. And what I like to know is like, what type of weight are you gaining, right? Because seeing somebody virtual is a little bit different than seeing somebody in person, right? So I like to talk about is what are your kind of metrics? What's your skeletal muscle mass? What's your body fat percentage? What's your water? What does that kind of look like for you on a daily basis? Because just having weight gain doesn't tell me a whole lot.
Right.
Yeah,
It could be the right weight gain. It could be
correct. Correct. Which is something I deal with, not to sidetrack here. That's something I deal with patients that start hormones with me. They're
yeah.
like, well, I'm gaining weight. I'm like, okay, but what type of weight are we gaining? So it is nice to kind of have some metrics for me to look at, like whether that's with a DEXA in body, whatever you have access to, because being virtual, I use that as a tool in order to treat you. And also, too, can help for my women if they start testosterone, they gain some weight. If it's muscle, that's great.
Yeah.
That's awesome.
Yeah.
Well,
Um, to kind of put like fears aside, we've learned a lot in the last 20 years regarding hormones. I mean, my goodness, testosterone's still not FDA approved for women.
No.
Thankfully, I love compounded testosterone because I don't really want it to be FDA approved for women because then it's going to cost more. It's going to be in a pretty pink box and it's going to say, oh, this is for women, right? Just kind of how they do like with period tax and wedding and all of those things. I think that would happen with testosterone as well. You just have to be careful with dosing, making sure you're working with a good provider that's monitoring you. That's
Yeah.
something I talk to both my men and women about is the fear is because patients are going online or they're getting it through a friend and they're not being monitored. So, like, well, my friend took testosterone and they had a heart attack, or my friend took testosterone and they started having roid rage. I'm like, well, they weren't being monitored. And actually, roid rage is from high estrogen. But so it's just really education. I will tell you by the time I am done with a patient, they're fine with it. It's just spending time and actually meeting having them vocalize their fears. What exactly are you fearful of?
Yeah. Breast cancer is one of the ones that pops up. If you don't mind, how often do you hear that?
Less and less every week, which is amazing. Because yes, we've came a long way in the last 20 years, and I already talked about bioidentical hormones. There's a few actually studies out there that show bioidentical progesterone micronized actually decreases the risk of breast cancer, which is super cool. We're kind of out on the verdict with testosterone, whether that's protective or not at this point against breast cancer. But I think it's just been ingrained in our brains, right? Susan G. Komen, Breast Cancer Awareness Month. But if you really look at the statistics, they're about the same. as far as mortality goes with breast cancer. So, still fearful, still needs to be an individualized conversation, which is why I don't like to put things blanket out there. Statement wise, still needs to have that. We need to have that one-on-one conversation. Do the benefits outweigh the risk for you? Majority, 99% of patients, I think they do. But it's having that open conversation.
Yeah, I know.
Oh,
I was
sorry.
just going to
Go ahead.
just real quick, I want to talk to the bros out there, right? Because even though we're talking about the female side, the guys are tied to this. If you're going somewhere and they are putting you on TRT and they are not checking your freaking labs often enough, Jordan, I have sent people to you that are literally 5, 6 times the high end of a starting dose, right? And I'm like, I've got to get you away from these providers. You've got to come work with Jordan so we can monitor you and you're safe. If you don't mind, talk about that dosing. And I know it's hard to say, well, you just start every female at this dose, right? If you
Mm,
don't mind, talk about a typical starting dose and then the different ways to administer it, if you don't mind, because I've got
yeah.
clients listening right now that I've told them, listen for this podcast because we're going to break. I can explain it to it, but I'm the diet coach. I want you to hear it from the nurse.
Yeah, so with women, I usually stick with either weekly or biweekly subcutaneous injection testosterone. I will usually do around 10 milligrams, honestly, for a majority of my women. And same goes with a cream. So a lot of times I will do anywhere from 4 to even 12 milligrams cream wise. I will say this too, John. I used to be really against creams because I was in the men world, the
Yeah.
men's testosterone world for so long, and I couldn't get men's levels up with androgel and things like that.
Yeah.
But the compounding pharmacy that we utilize, that I've also known for 13 years, their cream base is incredible.
Yeah.
Honestly, I can raise serum level. So I no longer have kind of that misunderstanding. I think it was just the androgel. It is the problem there. But I would say that, yeah, around 10 milligrams daily or 10 milligrams a week on average.
What about the
Yeah.
pellets? I have a lot of
Yep.
people that have wanted us to talk about this for a while. Talk about that. I'm not
I love
personally.
to talk about it.
Yeah, go ahead.
Yeah, that was one thing on my list I would love to talk about. Here's the thing. If I am a patient, if I was a patient, yes, pellets, easy, every 3 months, every 4 months, I can understand the appeal there. However, you have to understand specifically, and we'll talk about women first, and then we'll separate this and go to men. Women in perimenopause vary month to month. Like everything varies month to month. So if we put pellets in, they're in. That's it. Okay.
Yeah.
So that can become a problem, especially if someone looks like on lab, because that's the other issue too, with pellets is they typically go by your labs, not your symptoms.
Right.
Okay. So they're just chasing labs. They put them into a computer, tells them how many pellets to put in, all of that. Well, you're not a computer, right? So the human body is not a computer. It doesn't talk about outside addressing factors, cut phase, all of those things don't go into that. So if you put pellets in, and let's say it looks like that you are almost don't have any estrogen. Well, that doesn't mean in 2 days that estrogen isn't going to spike. So if you put pellets in, it could add fuel to the fire. So I do not love pellets in perimenopause because things change so rapidly month to month with my women. But also, I don't love them in the postmenopausal female that is postmenopausal, 4 to 5 years that hasn't had hormones because I don't know how your body is going to react. I
Yeah.
really I don't know how long it's been since you've had progesterone. I don't know how long it's been since you've had estrogen. I can guess, but that's not 100% science. So I think if somebody is dialed in for a few years postmenopausal, pellets could be a great option for them. That's very few and far between.
Yeah. I
Yeah.
have clients that guys as well. They get about 8 weeks in and then
But
they
I was
start
going to
to
say,
tank and you're stuck for about 3 to 4 weeks where your levels are low and you just have to ride it out to get the next. So it's like it spikes high and then it tails off and then you burn through it and it's done. I just don't know why that's even a good idea to even go that route just for that fact alone.
Mhm.
So
My men, so that, exactly, you took the words out of my mouth with men. They burn through them. They're like, oh my gosh, I was on top of the world for, like you said, about 6 weeks. And they're like, oh, and then now I'm back, I'm depressed. I think I need to go, I think I need to go make sure I get my refill of my depression medication. I'm like, what is happening? No, it's just because pellets don't work well for men. I mean, if you have clients that are men that have done well on pellets, I would love to hear from them because
Wow.
I have treated thousands and thousands of patients, and I don't know anyone that loves pellets besides that postmenopausal woman that is pretty dialed in with their hormones.
Yeah. Yeah.
And
And that,
they're a waste of money, in my opinion.
yeah. Okay. Well, I mean, there it is. Like roll credits. I don't think we could talk about it anymore. Like you just, yeah, boom, mic drop. Lisa, what do you
I
have
had
for
a
me?
question to the topic earlier in regards to estrogen and the fear around breast
Yeah.
cancer. Obviously, that's also something I hear often, but maybe not all of the listeners are aware of where that quote unquote myth even came from and how that has been quote unquote debunked since that or in the last, let's just say 10 years or whatever. Maybe you could explain how a certain study kind of brought that myth into the world.
So Women's Health Initiative in the early 2000s is where that came from. So it scared every primary care doctor, every OBGYN away from hormones. They're like, nope, hormones are bad. But it really wasn't hormone. The study itself was not flawed. The interpretation of the data was flawed, is what I like to say. So they were using conjugated equine estrogen. They were interchanging progestin with progesterone. And they're not the same thing. They don't behave the same in the body. So oral birth control, yeah, those are synthetic hormones that the Women's Health Initiative kind of followed, if you look at that. Not to go off topic here, I believe in pregnancy prevention. I believe people should have access to it if they want, but I really don't love oral birth control. My favorite form of birth control is a vasectomy, followed by copper IUD, followed by Mirena. That's 1, 2, 3 right there. So kind of, but what's interesting with that Women's Health Initiative, they came out and took all these women off of their hormones, but they kept everybody on oral birth control and still hasn't revisited that at all, which is
Right.
interesting.
And
I think it'll be coming.
to my knowledge, correct me if I'm wrong, but to my knowledge, the women in this study were also like 60 plus as opposed
Yes.
to perimenopausal or in the menopause transition. So really not exactly what we're talking about here in the sense of, yeah.
Yeah. And I too, with my patients that come to see me, I make sure, and I talk to them about that. I'm like, yes, I think you need hormones, but we also have to work on getting your A1C down. We also have to work on getting glucose down, all these other things, because otherwise I'm putting hormones in and getting the fat percentage down, visceral fat down, because otherwise I'm putting hormones into this body that is not well. It's not going to do well.
Right. Yeah. And I guess speaking of the age brackets here, and I know that that's a question that we had scheduled for later, but I want to intersect it now.
Yeah.
So when, in your opinion, is a good time for women to think about starting HRT or not? Because someone in their early 40s or late 30s even might be like, I'm not feeling like myself, but isn't that way too soon? Should I be replacing some of my hormones?
Yeah. So I love getting labs in women in their 20s, actually, starting. Now, I'm not necessarily potentially going to start hormones, but just to have that baseline of where are your hormones at during that time. A lot of women and our environment, the things we eat, all the things, average age of menopause is 51, 52, but I'm seeing women go through it in their 40s. I have women in their 30s on hormones with me. So very individualized. I think it's sitting down with a provider, having that in-depth conversation about your symptoms, and then where do your labs correlate to those symptoms. And I look at my patients as not what is a problem right now, but I do look at it what is a problem right now, but what potentially could be a problem 5, 10, 15 years down the road, right? So to answer your question, I'd say early 30s.
Mhm.
You need to get a good thorough set of labs.
Awesome.
Same,
And
same with guys. Same with guys. You
Yeah.
recommend
Oh,
30?
well, that's loaded because I have
Yeah.
my brother, and he won't care if I talk about him right now. He was student body president in high school. athlete, he went to college, all of a sudden just got depressed out of nowhere. Everyone kept saying, oh, it's the change in college. I'm like, no, something else is wrong. Went to see his doctor, tried to put him on a little bit of anxiety, depression medication. He didn't take it because he called me first. His testosterone was 108 total.
Wow. Wow.
108 total. So
At the
I had
90.
to go, yeah, like no wonder he's depressed. No wonder he's not sleeping. It's not just because he moved away to college. You don't go from being student body president, star athlete, that type of personality to this recluse. You just don't overnight. So my men need to get checked sooner.
Yeah.
18.
Yeah,
Yeah.
in my world, I see a lot of type A hard chargers, guys in their late 20s trying to operate businesses. I've got one of my clients now that has a lawn care business and he owns it. And it's just, I mean, the turnover there is high and he's just pushing hard, hard, hard and sleeps slow. Well, we're struggling, right?
Mhm.
Because, to keep his hormones in a good place, it's that highly stressed type A type of individual. I see that from.
Mhm.
But then the other thing too, and this is probably a whole podcast in itself, but then you have someone that may start on hormones that maybe wants to start a family later. So then there's that conversation. And that's why you're the perfect person,
Yeah.
not John, the diet coach, to have that conversation. We've got a lot of bros listening that want to have that conversation. No, you need a Jordan or another practitioner to be able to have that conversation because that starts to get pretty advanced, correct?
For sure, for sure. And that is where you just have to talk about your labs, where they're at, their goals for now and in the future as well. Because there are things I can do more naturally sometimes to increase testosterone levels. Just having vitamin D, like optimizing your vitamin D is going to increase your testosterone, strength training, all of those things. Fenugreek's a decent option there too. So, but that's where I say it's never too early to get labs. It's just not because I think for me, I would love to have taken 28-year-old Jordan and had a thorough set of labs on her, right?
Yeah.
Not this basic graph that doctors typically and providers draw. I want the full panel because I think that I wouldn't have went through that journey that I did. In hindsight, it's 2020. I think I'm glad I did because it makes me a better provider, ultimately for my patients, because I've been there and I've kind of been in the trenches and had all those symptoms too. Um, but yeah, I think it's never too early.
And I think to the point of reference ranges as well, I have often heard from people like, "Oh, my physician says my testosterone is quote unquote normal, as you're saying, or is in the ranges, but I don't feel like myself, blah blah." And so if you have that reference range of like, well, 5 years ago I was at 1,000,
Mhm.
and now I'm at 300 or whatever for you, that's a huge drop for you. For someone else who was on 400 or whatever, it depends on
Yeah.
your own reference and not the reference range around you.
Yeah, absolutely. So I always talk about the difference between normal and optimal, right? We don't want to be normal because normal is unwell. Those lab ranges are defined by an unwell population.
Right.
Mm,
Specifically, too, with women with testosterone,
yeah.
a 40 is considered high on labs. Most of my women feel best around 40 to 100.
Yeah.
That's where they feel best.
Right. Yeah, no, I love that you're striving for optimal because I mean, obviously, John and I and with our clients, we push for optimal as well. And so
Mhm.
you mentioned a few things that people can do or can look for
Yeah.
if they're not wanting to look into the hormone route. You mentioned things like cortisol and stress management. You mentioned vitamin D, vitamin B. What are some other things, whether that be supplements, lifestyle practices, or anything else that you can think of that people can take away from this podcast?
Yeah, sleep hygiene, kind of talking through that. And that's something a lot of times in your control. I don't love just giving, once again, like ashwagandha, L-theanine, things like that without getting that cortisol pattern, just because I feel like then I'm just throwing things at something I'm not quite sure what I'm doing. Uh, you know, so I want all the tools there. Diet, lifestyle, just putting the screens away, trying to be more involved, with kind of your day to day. Yeah.
Bit more mindful, bit more in the
Yeah.
present moment.
Yep. Yep. Which I saw was one of your goals coming up.
Yes, absolutely.
Yeah.
Yeah, I think it's for everyone. I mean, we're always, especially if we're that type A sort of person, and we always want to chase the next thing, and that's all great.
Yeah.
Also, just not missing life in the present moment, I think is so important. And John, you spoke about that when we were talking about the Fat Muscle Academy the other day, that your mentor actually said to you, take it all in, enjoy it, because
Uh-huh.
you're not even absorbing it all.
Yeah.
Look what you've created here. And you're like, oh, yes, but it all needs to go so well. So we all need that person who's like, hey, enjoy the present moment.
Yep.
Yeah.
Yep. Absolutely.
Real quick before we forgot one set of people to talk about, and that's the
Okay.
guys. Just real quick, um, on a typical starting dose ish, because it's all across the board. So I want to shout out again my bros listening who have been using black market testosterone, which I absolutely hate because you do not know how much you're taking. First of all, it's black market. You don't know if it's sanitary. But the main reason why I think doctor or nurse practitioner prescribed, medical professional prescribed TRT is important because for that subset of people out there that have been using their own testosterone, whoever they get it from, you hear of things like guys using 500 a week, right? Or 700. Well, that's because it's not potent. That's why it's black market. So, we can see 200 taken a week, and that is literally going to get a guy sky high. If you took 500, there's no way. Like, there's no
Yep.
way. So, all you guys out there that are taking these massively high doses, it's because you're using massively underdosed black market stuff. So, now that I've got off my soapbox, Jordan, can you talk about typical starting doses and kind of what you prefer? Is it the same thing, injections you prefer first and then gels and then, from there?
Yeah. Like I said, we have a really good cream base with our compounding pharmacy that I've been able to get serum levels up on my men too. It's about, and this is something I didn't mention, is with hormones, everyone's like, what's better? What's this? It's like, what are you going to be compliant with? What's going to be easily integrated into your life, right?
Yeah.
Because there's a lot of things, and you know this, John, you know this, Lisa. Like, if you want somebody to take a supplement 6 times a day, it's going to be pretty hard. It's going
Yeah.
to be pretty hard, right? So, I am always that provider that meets the patient where they're at. Once again, what's going to be easily integrated in their life? Starting dose, though, of testosterone, well, I prefer testosterone cypionate just because we have the most research on it. The data is there. Occasionally, I'll do a tri blend with patients. Pretty rare, but 150 actually is starting dose, 150 milligrams. That's kind of average starting dose. If I do kind of have a patient in their 60s, maybe late 60s that's starting with me, occasionally I'll do 100 or 120. But average starting dose is 150 milligrams. Then I repeat labs in 6 weeks. Just to make sure, hey, is our dose appropriate? Are we having hematocrit problems? How's everything going? So I'm not flooding their system quite with that 200 yet, which I would say in general, most of my men are on 180 to 200 milligrams. That's
Yeah.
pretty standard. Occasionally, if receptors are, they've really been on testosterone a really, really long time, occasionally I will have them split like 225 to 250 is kind of max for me.
Yeah.
And more is not better. That's the biggest thing I have to get through my men. I'm like, listen, yeah, I know you want to be like your buddy and have your levels 3,000, but you remember last time that your levels were 3,000, you were calling me, we were having issues mentally, physically, recovery, sleep, because it works the opposite. So more is not better.
Yeah. Can you talk about that real quick? Some of the side effects that
Yeah.
come with testosterone a little too high? Because so me personally, and I've been doing this for 5 years. I've tried 200 a week. I typically take about 120 a week, and my levels come back at about a 750 total. But
Mhm.
my free testosterone is actually just a tad high. It's like
Perfect.
250 on the range, right? Now I feel great here. My estrogen's not too high or anything like that. I personally feel good here. Blood pressure is decent. Can you talk about when someone gets too high and the things they need to look for?
Yeah, so headaches, fatigue. You're saying, oh my gosh, I'm taking all the testosterone, I don't feel any better.
Yeah.
Recovery, once again, sleep. But I'm glad you mentioned the free testosterone because I think there's a lot of men out there, and And it has changed a little bit in the last 10 years, but a lot of men are comparing numbers. I know how this goes. My women are the same way,
Yep.
but they're not looking at, they're only talking about total testosterone. They're not talking about free testosterone. They're not talking about sex hormone binding globulin. They're not talking about estrogen, all those other factors that go in. So, what I would say to your clients and your listeners is you really have to stop comparing yourself. You
Yeah.
really, really do, because your goals are not the same as your buddies. Like they're just not. And maybe your comorbidity conditions are not the same either. So you have to take that into account. And you said, well, I feel great at this. That's exactly right. And my men, it's hard because a lot of them have like math, they love spreadsheets, they love all those things. But they are like, well, my testosterone just dropped just, a little bit. We need to go up. No, let's pump the brakes for a second, right? And kind of look at that overall picture. And how are you feeling? Are you feeling good? Are you still sleeping good? We don't need to change your dose. Yeah.
I love our super bros. I just love educating them. One of the things guys need to be super aware of too is when it gets really high and it converts over into estrogen,
Yeah.
you need to be prepared for that. So, and I don't know if you want to talk about any of the anti-estrogens or importance, but you can get man boobs. Like that's a
You
very
can.
real thing. And if you're a fatty, you got to be careful with stuff like that. And then your buddy, like you're talking about, when you're comparing, can use twice as much as you do and never get it ever, or you get the
Because he
one
doesn't
guy.
aromatize. Yeah.
Yeah. So then you get another guy that gets it real easy. So is that something, do you have to have that conversation with different guys to watch their estrogen for that?
Yeah. Yeah. And occasionally I will use DIM. Occasionally I will use anastrozole. I know that it's been, lately it's like, no, if you're going to a clinic that does anastrozole, you need to get out. Well, everybody's a little bit different, right? And if they're having a lot of high estrogen symptoms with their labs correlated, then I will use it very short term. It's not my goal long term for them, but I want them to feel better too.
Yeah.
So I'll try DIM first if that doesn't quite get it. And then because the one thing my men do not like me lowering their testosterone dose, that's for sure. But I have to have that open conversation because sometimes, hey, it's time to lower your testosterone. We've tried all these other avenues. You're just converting too high, or we need to get, or microdose tirzepatide, semaglutide. We've got to get your fat percentage down so you stop converting. It's
Yeah.
just a larger conversation is really what it comes down to. And I don't think that majority of people are getting that quality of care. They're just not.
Yeah. And it's one thing too. I can speak to this just to the guys out there. I use a Arimidex very, very tiny, tiny dose. And I got that prescribed from my doctor back in 2019 because I was using 200 a week and my estrogen did get a little bit high. Well, over time, as I slowly lowered that down after talking to doctors and I got to 120 a week, my estrogen slowly came down, but I was still using Arimidex. So at one point, my estrogen got low. And that's where, going back to our earlier conversation, brain fog. Now, you spotted this on my labs and had the conversation with Brandon whenever he met with me. I also used cholesterol medication and they were combined. They were just a little bit too high. So then my cholesterol is low. When you talk about having both of those low, I was dumb
Uh-huh.
as shit. Like I could not remember anything. Jacob's laughing at me. I'm like, dude, I literally can't remember what I was just going to talk about. I thought it was stress. It's not. It was low estrogen, low cortisol, stuff like that. So
Low
I
cholesterol.
just, yeah, I didn't know how much you have had to deal with guys on that end. So I know you're
I
obviously
have.
super aware of it. Yeah.
Yeah, for sure. And that's where comparing yourself, they don't have, your buddies don't have your cholesterol. They don't have any knowledge of your cholesterol. They don't have any knowledge some of them have some knowledge of estrogen, but not a ton. Estrogen's cardioprotective. It's good for the brain. I also see low libido and ED issues if that estrogen gets too low in my men. So now, when I bring up ED, then everybody's ears are open, right? To have
Yep.
making sure that that estrogen's that perfect balance. But cholesterol, something I think is important too, is that I think globally we have too low of a cholesterol problem.
I agree.
We have a majority of patients on statins that just bottom out their cholesterol, and we're seeing some cognitive issues for sure. I don't test a lot of omega-3 levels, not to go too far into this. I don't test a lot of omega-3 levels, but I do occasionally on patients. The reason I don't all the time is because it's expensive. But the omega-3 to 6 ratio, especially in the Midwest, is not where it should be. So, as far as supplements go, everyone should be on a quality omega-3. Everybody should potentially be on like a little bit of a methylated B complex. And then I would say vitamin D as long as you're being monitored on that one.
Yeah, good stuff. Lisa, I know I hijacked us a little bit here and there and took us off on some tangents. Is there anything you can think of or anything that you want to ask or follow up with?
No, honestly, this was amazing, Jordan. I love learning from you and just love the care that you're giving each and every client. And I'm sure someone listening here is going to be super interested in working with you as well. So maybe you can let them know how they can find you. And obviously, we will put everything in the show notes as well.
Yeah.
Sure. So you actually can book online through because that's we make that pretty convenient for you from our telehealth space. So you can through our website you can book online. So if you guys will drop that in the comments, just click that. It is a $99 consultation fee to see me, which is very minimal, honestly, compared to majority of providers out there. But yeah, no, I'm excited to see some more clients.
Yeah.
Amazing.
Thank,
Thank you
thank
for
you so much for, yeah.
Yeah.
awesome.
It's one of those things we'll have, Lisa will follow up. We'll book new, content, more stuff. Lisa, what do we have coming up next? I know that, go
Well,
ahead. Sorry. I was
we've
choking
got
on
we've
my
got
on
Renee
energy
coming
drink.
up, so one of our coaches, and she's going to be speaking with us in the next recording. And I'm really, really excited because, as you mentioned before, John, she's just absolutely crushing it, not just with her business, but also personally with her own training, with her own transformation. If anyone is going to check out her Instagram or her socials later, they're going to be like, "Whoa, can't believe she's looking this amazing." So yeah, that's going to be an awesome interview.
Yeah, yeah, we have really good stuff lined up. We really appreciate you. Check out the show notes, get a hold of Jordan. If you have any questions, you can email any of us, topics, any of that stuff, people that you want to see on the show, send us a message. We're going to keep knocking these out. For myself, Lisa, and Jordan, we're out of here. See you guys.